Time for some clinical peanuts.
Drawn on it.
Yeah, that's okay. That's because we have that's a software glitch. Whoever is doing, please let's respect. Yeah, please go ahead.
Okay. So, so our patient is a 28-year-old female who's a corporate employee by occupation and is a resident of Guntur. She came with a complaint of blurring of vision for distance and near vision and glare in both eyes since past 1 year with the present glasses. She's using spectacles since 11 years and has a history of frequent change of spectacles. Her last glass prescription was 4 months back. She has a history of occasional rubbing of eyes due to allergies. And since past 1 year, she developed blurring of vision in both eyes, which was more appreciated in left eye compared to right eye. Blurring of vision was gradual, progressive, and painless, and was not associated with redness. There was no history of trauma, no history of use of contact lens wear, and no history of any deviation of eyes since childhood. Her past history includes like negative history. There is no history of bronchial asthma, atopic dermatitis, and any other systemic illness, and there is no history of any ocular surgery. Um, her diet is mixed, bowel and bladder habits are regular, and sleep is adequate. There are no similar complaints in any other family member. Her general examination is within normal limits and vitals being normal. In ocular examination, her head posture is normal, facial symmetry is maintained, orthoperic ocular posture, and extraocular movements being full, free, and normal. Her refraction shows right eye uncorrected visual acuity being 3/60 with pinhole improvement to 660 with minus 6.5 cylinders at 10 degrees axis, and left eye showing 4/60 uncorrected visual acuity, which is not improving with pinhole or glasses. So first, I'll tell about the right eye anterior segment examination. Her right eye eyelids are normal, and external signs like Munson's sign and Rizzuti sign are positive. Regurgitation on pressure over lacrimal sac is negative. Conjunctiva is normal. This is the reference pictures. Cornea on diffuse illumination shows a central macular scar of 2 to 3 millimeters, which is linear and is in center. On parallelopiped section, fine vertical parallel lines are seen in the deep stroma in central cornea, disappearing on gentle pressure over globe, which suggests Vogt striae. On optical section, area of steepening is noticed in inferior paracentral cornea, which is coinciding with the area of thinning and scarring. Anterior chamber is deep. Iris has normal color and pattern. Pupil is round, regular, and reactive to light. Lens is clear. Anterior vitreous is clear, and NCT shows error. These are the pictures for reference. Now coming to the left eye anterior segment examination, the eyelids were normal. External signs again showed Munson's and Rizzuti sign positive. Regurgitation on pressure over the lacrimal sac is negative. Conjunctiva is normal. On diffuse illumination, there is a central round leukomatous scar, which is 2 by 2 millimeters in size. On parallelopiped section, there are fine vertical parallel lines in the deep stroma. in the central cornea, which disappeared on gentle pressure, which suggests Vogt's try again. On optical section, area of steepening is noticed in inferior paracentral cornea, which is coinciding with the area of thinning and dense scarring. Anterior chamber is deep. Iris pupil lens anterior vitreous is within normal limits, and NCT showed error. This is a picture for reference again. Vogt's try in the right picture. Posterior segment examination in both eyes is within normal limits. Only the left eye had hazy media due to the dense scar which is present centrally. So at this point, my provisional diagnosis is both eye corneal ectasia, which suggests more suggestive of keratoconus. We'll do further investigations. So keratometry, retinoscopy, and corneal tomography were done. The keratometric readings showed right eye K1 69.75 diopters and K2 78.5 diopters, having a cylinder of minus 8.75 at 95 degrees. And left eye showed 66 K1 and 71.75 diopters K2 with cylinder of minus 5.75 at 70 degrees. So it is obviously a steep cornea in both eyes. On retinoscopy, both eyes showed poor glow, so scissoring reflex was not appreciated. One minute, I'll just show the pentacam. Hello, is the screen visible, sir?
It's not yet visible. Yeah, now it's visible.
Okay. So this was the pentacam report of right eye. In this, we can see again that the K1 and K2 is steep, again correlating with our keratometry findings. The quality score here shows data gap because the ectasia is advanced. Advanced keratoconus or any other advanced corneal ectasia. If the quality score is showing data gap, we should proceed the interpretation of such a report with caution. But since this is advanced keratoconus, these readings are pretty much reliable. We can see the thinnest local is 303 micrometers, which is quite thin. And the AC depth is also deep due to ectasia. The axial map, the anterior curvature map shows frank ectasia as the red zone is seen. Here we can see a globus type of cone which has a broad base, and again the readings are steeper, like 78 and 70 and 68 in both the axes. In the pachymetry map also we can see grossly there is thinning in the central area, around 300 microns. Then the Bellin-Ambrosio display also shows frank ectasia. As the front elevation, the normal value should be less than plus 12. And here it is 67 and 29. Everything is above plus 12. And in the back elevation also, normally it should be less than plus 17. So again, it is showing frank ectasia. With the best fit sphere and enhanced best fit sphere also. And the difference map also shows red color, which is again suggestive of ectasia. The CTSP, that is the corneal thickness spatial profile, this shows the comparison with the normative data. So again, this is very thin starting from around 300. The red line, which is the patient's line, lies outside the three lines of reference. So this is obviously abnormal. The percentage thickness increase uh, score also shows that it is declining. It is a declining scope, which is slope, which is again outside the normative data. So again, suggest I as well. It shows a similar picture where K1 and K2 are very steep, and the thinness local is again very thin, and AC is deep, and the axial map shows broad-based globus type of cone, um, and the corneal thickness is also thin. In this case, it is 312. Again, the bad display shows elevation maps showing abnormal values and gross steepening, much more than the right eye. Again, suggestive of keratoconus. The CTSP and PTI index again in the left eye have a similar picture, which are abnormal to the compared to the normative data.
Yes, Dr. Raghav,
Uh,
you can go ahead.
Very well presented, Dr. Aboli. The details were really very, very good because you presented everything completely. So, this is your final diagnosis. You have any slides left, Dr. Aboli, or that's it?
No, sir, that's it.
Okay. So, what is the age of the patient?
Sir, she's 28 years old.
Okay. So a couple of things about the patient. So because we are discussing on this case, so why do you think there is scar in both the eyes?
Sir, in the right eye, the scarring is macular scarring, looks superficial. So it looks like it has been due to Bowman's membrane fragmentation. While in the left eye, the scar was quite deep up to the posterior stroma. So I think the patient did not give any such history, but it must be due to descending membrane breaks, which has led to some episode of acute hydrops. So maybe due to that, there is dense scarring.
In that case, the past history will definitely be suggestive, isn't it?
Yes, sir.
I mean,
But
because
she
it's
did
difficult
not.
to miss because they do have symptoms of redness and congestion. So that is
Yes,
one
sir.
thing. Or so, and in another way, in case if you are suspecting hydrops, what would be your investigation of choice in that case?
Investigation, sir.
So because now the
Slit lamp
patient is not
examination, the
correct.
cornea will show.
Because now you
it
have a
did.
dense full thickness scar, it's difficult to make out the details of the layers of cornea at this point of time. Is there an investigation we have where we can delineate uh, which layer is
We
involved?
can, yes, so we can do ASOCT.
Exactly. So if you can do an ASOCT through the scar, if there is a break in the Descemet's layer, probably you can suspect in lines of acute hydrops, and that is a very good investigation to do adjuvant to your pentacam. So one other advantage of what anterior segment OCT does is it also gives you something called as an global epithelial thickness mapping. So it will tell you what differential thickness of the epithelium over the area of scar in comparison to the other areas. So that again will give you a better cue for diagnosis of keratoconus in cases like you said, because this is a gross ectasia, because this is advanced keratoconus. You cannot rely on the topography because it's showing an error, it's giving out an error message. So in this patient, in case you want to do a cross-linking, uh, then that would be more suitable because now you know the thickness of epithelium as well as it will give you a nice central thickness of the cornea as well. So you know whether you can do it or not. Obviously, in this case, the thickness is 303. So I don't think there is any possibility of doing a cross-linking. So the
Awesome.
next question comes, what is the management of this patient?
Sir, we can try for contact lenses, but again, this is the RGP lenses or rose K lenses. We can give her a trial and see how much she can accept the lenses. Otherwise, there are surgical options like Bowman's membrane transplantation or DALC or just PKP, sir, penetrating keratoplasty.
So systematically for a 28-year-old, you've seen that the right eye vision is improving -6 with glass somewhere around 660, and left eye has no improvement, has an adherent glaucoma. So typically, what would you do for the right eye? What would you do for the left eye? Ideally, definitely, like you said, first thing you always want to do is a contact lens trial. Contact lens trial will help you, one, to rehabilitate the patient as well. You want to, and second thing, you also want to know what would be the best possible contact lens vision of this patient. Why do you want to know the best corrected contact lens vision of this patient? Because that will give you an estimate of how much the patient might improve postoperatively in case you are planning for any surgical management. So always the first step is definitely doing a contact lens trial. So what is one thing you have to note on contact lens trial? So on your examination slides, you have written everything. You have written about the fundus. What is that one important area of the eye you want to check before subjecting the patient for a contact lens trial? Or in other way, what other history do you ask in a patient of keratoconus?
History of allergies, sir, and lids we can evert and see for the
Yeah,
presence of
exactly.
papilla.
So yeah, that is exactly one point you can definitely include in your case, saying that patient first thing is the history of eye rubbing, either history of nocturnal lag ophthalmos also you can ask, and third thing is the postural sleeping position of the patient, whether the patient has a supine position or a prone position. There are studies which have shown that prone positioning of the patient also lead to increased risk of having a keratoconus. Then definitely you are eye rubbing. So to just rule it out, you can just elaborate saying that the upper tarsal conjunctiva, lower tarsal conjunctiva do not have papillae, and the patient has no symptoms of allergy. Only if they don't have symptoms of allergy, they will be good candidates for contact lens trial. Otherwise, it becomes very difficult. Biggest uh, landmark or biggest land break in these cases is allergy. In a case of keratoconus with allergy, it becomes difficult to rehabilitate them in any other way because even if you want to plan any surgical management in these cases, it becomes very difficult because of allergy, the overall ocular immunology is disturbed. There is a lot of pro-inflammatory mediators in your tear film, which can lead to adverse effects post-transplant as well. So you definitely want to look there and treat there before trying to take up a case for either contact lens trial or for surgery. So based on whatever you have, the information you have on topography as well, you elaborated topography really well. Even though it was very concise, but you gave all the points. So in a case of typical keratoconus, especially in advanced case, all the red marks on your maps will definitely give away the diagnosis very easily. It's very easy. Only when there are subtle signs, that is when the dilemma starts happening. So, what are the early signs of keratoconus on topography?
Yes, sir. So the K readings, first we have to see if they are steep. The again the thinnest local and the distance from the vertical distance from the center of the pupil to the thinnest local, which should be less than 0.5. Then we look at the axial map, sir. There are three maps that we have to look at: axial map, the pachymetry map, and the Bellin-Ambrosier map, the elevation map. So the axial map should have various shapes. So if there is steepening in the axial map, if there are symmetrical shapes like symmetrical bow tie pattern or central round or oval steepening is present, we have to see the keratometric reading. Like if it is greater than 47, there is some moderate risk of keratoconus. If it is greater than 50, it is again high risk in such cases. Another pattern is asymmetric patterns, which we see. If there is inferior or superior steepening, or if there is an asymmetric bow tie. So in cases of inferior steepening, if the difference between inferior and superior keratometric readings, K readings, is less than 1.5, it is normal. If it is greater than that, it is abnormal. But in cases of superior steepening, the threshold becomes 2.5. So if it is greater than 2.5, it becomes abnormal. So asymmetric patterns with abnormal K readings will have a moderate risk of keratoconus. Then there is skewing that we have to see. So the skewed radial axis should be less than 22 degrees. If it is greater than 22 degrees, it is again a high risk for ectasia. Then there are some special shapes like crab claw shape or asymmetric non-orthogonal bow tie shape or um, butterfly shape. Butterfly shape. These show pellucid degeneration, if we can
So it's kissing
suspect
toes or
like that.
kissing bird sign?
Kissing bird sign. Yes, sir.
Kissing birds or kissing toe sign? So
Yes, sir.
actually, what I was looking for as an answer was the ABCD classification. The ABCD, where you look at the anterior asymmetry, the back curvature, pachymetry. So it becomes very easy if you go in a systematic way so that you don't miss. And one other point I want to highlight is when you say 1.5 between inferior and superior, at what diameter of cornea are you talking about? That becomes very important. Are you looking at the 3 mm zone? Are you looking at the 5 mm zone? Are you looking at the 7 mm zone? When you say inferior,
So
superior
beyond
asymmetry
the
of...
3,
So that becomes very
I
precise
think it is
because now you
beyond the
have one
3
value on the
mm.
top, one value on the bottom. So
The second
what?
reading, sir.
Yeah, so correct. For 3 mm, it is around 1.1 is what we take, and 1.5 drops down to when we go around 5 mm zone. It becomes very important because where we are trying to measure it. Otherwise, any case, even without keratoconus, might be diagnosed as keratoconus because there can be one steep point somewhere else lying in the periphery. It's not very important. It's more central. And second, in this particular case, for the diagnosis of keratoconus, you could see that the entire steepening was more central, and some of these. Sorry, one second. So the most steepening was at the center of the cornea. That gives you again the diagnosis of keratoconus. So at this point, I would like to ask you, how would you differentiate pellucid marginal degeneration and keratoconus, both advanced, based on topography?
Based on topography. So pellucid marginal degeneration, sir, the inferior limbus, up to the inferior limbus, the thinning will be involved. Also, when we compare the pachymetry and anterior curvature maps, the in keratoconus, both the thinning and steepening will coincide with each other. But in pellucid degeneration, the thinning will be more inferior to the area of steepening. So that's how we can differentiate between the two now.
Excellent. That's an excellent answer. That is what I was looking for. So thinning is below, or the steepness is above the area of thinning in pellucid, whereas it is in and around the same points in keratoconus. Because in advanced cases, even in keratoconus, it might just stretch till limbus as well sometimes. So you'll have to be very careful in these cases. And anything else? Anything else with respect to genetics you want to ask for the patient? Is it a genetic disorder or it has no genetic predisposition?
There are genetic associations, sir. It is sporadic usually, but then there are genetic associations. So if there is any history in the siblings or family members or any even the first degree relatives, the first degree cousins, if they have, we have to screen the patient in detail because that has been linked to genes like LOX gene and VSX gene are involved in keratoconus, sir.
So typically in elder siblings, if you can see with the rule or against the rule, what would you see the astigmatism in keratoconus? Which is at greater risk, with the rule or against the rule?
Against the rule will be
Exactly. So
more.
if the patient's siblings, elder or younger, have against the rule astigmatism again, that again gives a clue that it can also be running in the family. Apart from that, the most important risk factor again cannot emphasize this stress on allergy, because allergy is the most important risk factor for having keratoconus. So coming back to our case, if you have to visually rehabilitate the right eye with surgery, what would be your choice of surgery, and what would be your choice of surgery for the left eye, and why?
For right eye, sir, I think a Bowman's membrane transplant or DALC will be sufficient for the patient. For the left eye, I feel since it is involving most of the layers of cornea, a PKP will be more effective.
So that brings us to an important question. For a Bowman's membrane transplant, what is the minimum thickness of cornea you would need to do a Bowman's membrane transplant? Can you do a Bowman's membrane transplant in any cornea, or is there a criteria for Bowman's membrane transplant?
Sure.
That is something you'll have to read. So, because Bowman's membrane transplant cannot be done when there is a certain cutoff of your corneal thickness as well. Second thing, you yourself have committed that there is some amount of fragmentation and scarring in the anterior corneal layers. So that again impedes us from doing a Bowman's membrane transplant in these cases. Also, the success of Bowman membrane transplant is yet to be established because there are mixed reports everywhere from the world. One of the reports from, surprisingly, both of us are at this point in Andhra Pradesh. There is one report which has come from Kakinada group as well, which have showed remarkable success in Bowman's membrane transplant. But everywhere else, the group from Japan, the group from Germany have shown that Bowman's membrane transplant doesn't hold well in with long duration, or long term outcomes have not been great. So that leaves us with a more age old way of doing things, which is DALC. DALC can definitely help in the right eye. So even in the left eye, we would definitely attempt for a DALC, even though you're assuming that even there is some amount of desmids involving in the left eye. We do try something called as a manual DALC, where we try to bare the area where the scar is, and then we would try to do a manual DALC and complete it. Why do we prefer doing a DALC over PK?
Because the chances of rejection in PK is more than DALC, sir.
So you have to give us the numbers. What would be what are the success rate of DALC? What is the success rate of PK? And what would be the rejection rate in DALC and PK? Those numbers are very important for everyone who's appearing for an exam or who are doing their fellowship as well. It is important to know the success rate, because why it's just not important for your exam, it is also important because a patient is going to sit in front of you. A 28-year-old is a well-read patient who can Google everything which is available for you. It's available for them. They're going to ask you what is the success rate? What is the rate of success if I do this procedure? What is your success rate of doing this procedure? So to answer those questions, you need to know what would be the success rate of DALC and PK in keratoconus. It has the highest success rate, but you have to specify the numbers. That is something everybody has to look into another aspect of it. So, and second thing, I don't know if I can go deep into the surgeries as well. What type of DALK would you prefer doing in these cases in the right eye?
I'm not sure.
So there are different types of DALK where you have something called as a big bubble DALK, then you have manual DALK. So there are different types of DALK we can do. So in keratoconus, usually a big bubble DALK is something we all attempt, and it 90 out of 100 times we usually achieve the big bubble, and it becomes very easy because otherwise corneal tissue is very transparent. So it's difficult to delineate at what level you are. So that makes it more important to know which type of DALK we do. Um, I'm sorry, I didn't get your introduction because I joined in late. Are you a resident or are you a fellow?
I'm a second year resident, sir.
That's great. So it's been amazing. You've answered really well for a second year resident. So probably more about surgery. I would not be asking more about surgery because it's going to be difficult to understand all the steps of DAL. But it's important for you to read up about at least the basic steps, what we do and how we do it. It becomes very important. And one other investigation, obviously, as we discussed, anterior segment OCT is something which is again making great strides in early diagnosis of keratoconus as well as in the management of keratoconus. So apart from our case, just keeping our case aside, what would you what if the patient, for example, this patient had a thickness of around 303 and somewhere around 330 in both eyes. So what if the patient had a thickness of 410? What would your management be in these cases?
Sir, we can go for C3R in cases which are more than 400
So
thickness.
again, so then you can go for a collagen cross-linking.
Yes.
What type of collagen cross-linking will you be doing? That is the second question.
So isotonic we can do, sir. But then since if the cornea is more thinner, like around 400 or a little lesser, so we can go for hypotonic also.
So can you tell me the composition of an isotonic?
Yes, sir. It is riboflavin 5-phosphate 0.1% along with 20% dextran in isotonic. Without the dextran, or if there is 1.1% HPMC, it becomes hypotonic, sir.
So off late, so I think this is something which is more recent. I think if you're reading a standard textbook, probably you would still say dextran. But off late, we have converted completely. We use HPMC and use it.
So I think we have lost Dr. Raghav.
Yes.
We'll just wait for it. So Dr. Aboli very nicely presented, and you mentioned that the IOP could not be recorded. So what are the best methods to record IOP in a case of keratoconus?
We can use an eye care, sir, because even
What is an eye care?
the eye care device that we can use.
Very nice. So what is the principle of it? What type of tonometer is it?
Sorry, sir?
What
What
type
type of tonometer? It is.
Because you understand, I'm not a cornea person, so I need to ask something different.
It is a contact type of.
Very good. So there are a lot of types of contact tonometer. So this is how Viva goes. You understand, your Viva will be, you have prepared 110% about keratoconus, but they'll not ask you a single question. Your Viva will be only on tonometry. So what are types of contact tonometer?
Applanation tonometry.
Very nice. So why wouldn't you use an applanation tonometer?
The Myers will be irregular, sir. We won't get regular Myers, so the reading is not.
So which is the best? Is there a best? You said eye care. Is eye care a applanation tonometer?
Not applanation.
Right. So what are the other methods which can, what do you say, overcome the problem of corneal mechanics? Or as you, the clue is if the shape of the eye, if the counter of the eye is
Uh, I don't know if we can try Shiots in this case.
not at all, we are not, that would be a dead end,
Yes.
right? So there's something called DCT, Pascal.
Pascal.
So basically, you have to eliminate the corneal biomechanics. So either you can go for a ocular response analyzer, ORA, or you can go for a DCT, I think dynamic counter tonography and tonometry, and so which is a Pascal. But what studies have found that there has been no difference in all the three. So even in the late stages, you can go with an applanation, and if the Myers are visible, okay, but applanation should be tried out in all cases, okay, and though as such by general thing we feel that a ORA or a Pascal would be better, but in studies there has been no difference, okay, and for exam point of view you should not talk about chiots in case of keratoconus. Okay. And off to Dr. Raghav after the
I'm
commercial.
sorry, I just got disconnected. Like I was saying, I think we did cover most of the parts. Uh, one other clinical sign, because you are a resident, it's very important. Can you tell me one other clinical sign on slit lamp which you couldn't make out?
Fleischer's rings.
Yeah. So Fleischer's ring is important among all the other clinical signs. Obviously, I think from an exam point of view, you would want to know all the signs of keratoconus. But Fleischer's ring has a special place in the diagnosis. Why? Why is marking the Fleischer's ring important?
Sir, because it demarcates the the extent of the cone, and in cases of surgery, we can make sure that
Exactly.
that cone is
So
covered.
even if you are doing a cross-linking, or even if you are doing a DALK or PK, it's important to mark the Fleischer's ring. So I try to do it even in my cross-linkings, because what happens in these patients effectively, most of them do have some amount of limbal stem cell weakness because of chronic allergy. So in case we are trying to remove epithelium almost till the limbus, they can have secondary problems because of that as well. So what I try to do is just mark the posterior or the inferior extent of the cone. That will give us a guide till where we need to remove the epithelium even during cross-linking. But more importantly, during surgery, if you at all miss taking off the cone completely, there is a chance for inferior temporal ectasia to happen from the remainder of keratoconus, whichever is there. So that is another important sign. And second thing is age of the patient. One thing we were talking about cross-linking. The patient is 28-year-old. So do you still want to cross-link them at that age, or you would want to observe? What is the trend in age for keratoconus?
So with age, sir, natural cross-linking happens. We can see the progression of the uh, keratoconus over 1 year time period if it is if it is not severe, obviously, and then based on the uh, comparison of progression, we can decide if we want to cross-link or not. So we can see for keratometric values, the visual acuity and pentacam readings to see the progression.
So that becomes an important question. How do you monitor progression on topography?
Uh, Sir, the thickness should the thickness pachymetry changes should not be more than 2%. So if it is greater than 2% increase, decrease in pachymetry, then we can.
So I feel that practically it becomes very difficult if you say 2% every time it's difficult to measure 2%, 300, 2%. So what we generally do is around, do you have a number? So 10 to 15 microns is what the standard deviation of the machine pentacam is. Anything more than that, somewhere around 30 micron, greater than 15 microns is where we start thinking there is some amount of thinning which is happening. And any difference in the keratometric readings?
If it is greater than 1 diopters, we can.
And 1 diopter for how much duration?
1 year, sir.
So yeah, this has to be very important because it cannot be 1 diopter in 5 years duration. And practically this happens as well. Someone has come at when they are around 14 years old. The next visit they are coming at 17. There is a 1.2 diopters increase in 3 years. Do you still want to do cross-linking or you still want to wait? That becomes an important question because you don't know when the progression happened. So effectively it has to be in 1 year duration. 1 year duration, 1 diopter increase or 15 microns change is what we consider as significant change in keratoconus. uh, Sometimes it becomes very difficult, or uh, the patient and patient's attenders, because most of the times they are very young, they're very skeptical to wait for a longer duration of time. Then what we do is half of what it is. You can redo the scan at 6 months duration and try to see of a change of greater than zero point 0.5 or around 10 microns difference. That is what we take. So that is very important because that is how your guidelines will that's how your guidelines are. And second thing about the age, what is that age where you can say that the natural cross-linking has taken over completely?
Completely 25, I guess.
So
guessing.
that was a trick question. There is no age where you can say that it can happen completely. What we consider is above 18, we can definitely wait for the next 6 months or 1 year and redo the scan and monitor progression, because of late we have been seeing lot of progression among the 20 to 30-year-old age groups as well. That becomes another important point among cross-linking. And then because you are a resident and you'll be going for exam, it is very important to know what is Dresden protocol. What is Dresden protocol?
Yes, sir. So the energy is kept at 5.4 joules per centimeter square, and for 30 minutes we have to give 3 milliwatts per centimeter square of energy of UVA radiation. So
And
yes,
sorry, go ahead.
in a riboflavin impregnated cornea.
How frequently do you apply the riboflavin?
Every 5 minutes.
Okay, what protocol? I'm just asking because so that it becomes a revision for you. What is the accelerated protocol?
Accelerated means we decrease the time to 10 minutes and increase the energy to 9 milliwatts per second per centimeter square, and the effective energy that is applied is 5.4, again same constant, sir. We can reduce the time again to 5 minutes and 3 minutes, but 10 minutes is more effective.
10 minutes is more standard, which is followed around the world as of today. And do you know any other types of cross-linking?
Yes, so thin cornea, we use hypotonic solution instead of isotonic, and there was mention of contact lens also, like we can use the contact lens after debridement and then do in thin corneas.
Yeah, so contact lens assisted cross-linking has been something which has been growing. Again, the data about contact lens assisted has been increasing. If you see recent trends in paper after 2020, most of them are trying to talk about contact lens assisted cross-linking. Another cross-linking is where you selectively only target the cone. Localized cross-linking is something which they are trying to do. Do you know any other disease where cross-linking is being used?
In uh, ulcer, sir, or to strengthen the cornea.
What do we call it?
Not able to recall.
So we call it PDAT, photodynamic antimicrobial therapy. So that is something which again is being used for acanthamoeba, large fungal ulcers, pythium keratitis. It's being used. The key difference being we don't use riboflavin there. What do we use there? We use something called as rose bengal is what is being used. So I have seen I have attempted DNB exam myself. Although I did my master's, I did my DNB. So in a DNB practical, you can never know how far your external examiners go. So that is the reason I'm just trying to cover all the areas where they can touch up upon. And we did discuss about fleishing. We did discuss about the history and examination as well. So examination, I feel you should be able to definitely say all the signs very easily if we are discussing a case of keratoconus. And I think in the chart section, somebody asked about cares. So in this particular case, I don't think cares can be done because the thinning as well as the ectasia is more central. So if your ectasia is more paracentral inferiorly or superiorly likewise, then case will come into picture. Second thing again, case has a definitive algorithm about what corneal thickness you can do your case. So in it, the minimum thickness is around 400 microns where you try to do it. 400 microns was the cutoff for both the intacts as well as cares as well. The different thing about cares from intacts, just because there are so many residents listening to us today, I just want to say is in cares we try to use an allogenic corneal implants where they're either cross-linked allogenic implants which are just basically your cut parts of your corneal graft, or which have been subjected to cross-linking. We try to tuck them into the ring areas which we are making using a femtosecond laser. That is how we do cares. Cares is something very again which is evolving now. Initially it would be done only using a femtosecond laser. Now we do have something called as manual cares as well, where you have instruments where we can make incisions with guarded knives and try to make two tunnels, superior and inferior, and try to tuck in the allogenic corneal implants. So that is cares. And in this particular case, obviously, there is no way we can do cares, or I feel we shouldn't be doing Bowman's membrane transplant as well because the thickness is very, very less. In these cases, in even when you're attempting a Bowman's membrane transplant, there might be cases where you can have a full thickness perforation as well. That is why a good idea would be to do a full thickness transplant. If you do have any other doubts, let me know. And otherwise, I'm done with the discussion. Over to you, Dr. Anuj.
Thank you, Dr. Raghav. So I think Dr. Aboli can tell us what is the full form of cares for everyone.
I actually don't know, sir.
So
Have you heard of CARES before, or?
No,
so
I haven't read about it.
I feel that because as an Indian you need to know. So
Yeah, because again, you live in very close proximity from where it started and it's taken off. It was started in Agarwal. So CARES is basically corneal allogenic intrastromal ring segments. Um, I forgot,
yeah,
Doctor, I forgot
Dr.
her name.
Susan Jacob.
Yeah, Dr. Jacobs has like was started from inception of CARES, and she has popularized it. Now it's all over the world. Everybody's attempting CARES. Dr. Rajesh Fogla is also working a lot on CARES as well, although he prefers doing more in tax.
So doctor, do you know what is intax?
Intracorneal ring segments, sir.
Yeah. So as Dr. Raghav said that these in cares what we are using is a allogenic
Allogenic graft.
implant. So it is basically a corneal implant, and which I think earlier they were using it from the smile
Yeah. So even now, that is another different technique they've been trying to use. Another technique which I was a part of when it was being done in LVP is where we used porcine cornea. We would try to take a small, probably 80 micron or 100 micron lenticule from pig's eye. It would be bioengineered again. Riboflavin, again, it would be subjected to cross-linking, and then we would create a small pocket like how we do it in Smile, and we would tuck it in. The results were not so great. That's why it never gained to popularity. Um, this particular technique, which Dr. Anuj is trying to tell you, is again popularized in Narayan Netralaya, where they try to use a smile lenticle to tuck it into the anterior stroma.
So Dr. Aboli, you can tell us what is SMILE?
Small incision lenticule extraction, sir. It is a refractive surgery, which is new actually,
It's now.
recent advance. I mean,
So whatever the lenticule you extract from that, so the same lenticule is used to strengthen the cornea.
Yeah.
So you have weakened one cornea and you are strengthening the other cornea. Though technically speaking, SMILE is not supposed to weaken it, but just for the sake of understanding.
It's basically all this comes under so in your recent advances paper again we call it as corneal additive procedures, CAP, where you are trying to add something onto the cornea. It can be your intacs, it can be your cares, it can be the smile assisted, so lenticule assisted basically. So all of this will come under the additive procedures, which are gaining a lot of popularity of late, because the advantage with the additive procedures is it tries to normalize the corneal keratometry. So, and also it will increase the thickness. So, two major problems with keratoconus is it causes thinning, then it causes cornea to be abnormally steep. So, what adding tissue makes it is it's trying to again put some compressive effect on the cornea, trying to thicken, which is basically strengthening the cornea, and also it tries to flatten the corneal radii basically. So, they're gaining a lot of attention right now, but we'll have to again wait and see how successful they'll be in the near future.
Are there any oral treatments? Can we, for cases of keratoconus?
I remember there was this one drug which would be used, but I don't think it again works. It is more of a theoretical benefit that you'll have to know it. Anything else?
Maybe Dr. Raghav, you can just explain that for our people who are in the OPD, like when to suspect in a case of astigmatism, and what would be the signs on keratometry where you should go ahead with a topography.
So that's a very good question. Thank you for that, Dr. Anuj. So what I follow or what the practice pattern has changed over the last 10 years, over the last 10-20 years, because now we have a lot more topographers. Before we would rely more on the retinoscope to make a diagnosis of keratoconus, but of late we have been having a lot of topographers. There are so many companies which are making topographies. So what we are trying to do is anytime we have a patient who's typically of that age between 4 to 10 and has against the rule astigmatism, then we are very skeptical in these cases. If the power of astigmatism goes beyond 1.5 diopter, then I definitely try to do a scan for them to see whether that is normal or not. In doing so, we are able to find a lot more patients who have a regular astigmatism. Sometimes regular astigmatism can be somewhere around 3 to 5 diopters as well, and these patients will be some amblyoptic to 612 as well, but they will not have keratoconus. So this is something which is again very new. We are trying to find out by doing a lot more scans than before. To answer your question, anything against the rule astigmatism, power greater than 1.5 diopter is somewhere I would like to do a topography and see whether it is suspicious or not. And if in case, obviously not all places are furnished with having a topography. So in these cases as well, you can do a keratometry, a simple automated keratometry on your AR machine as well also gives you whether the corneas are steep or not. If the corneas are steep and there is significant astigmatism, then obviously these patients have to be subjected to a topography as well. In the same order of how she presented of having keratometry followed by a topography. In case you don't have anything, you still have your own retinoscope. So you can definitely do a retinoscope and look at the split reflex or the scissoring reflex. And that again is a very good cue for keratoconus.
Thank you, Dr. Raghav. I think that was very helpful, and you've made it pretty simple. So, Dr. Aboli, if you have any questions, because we have asked you a lot of questions, so any questions for Dr. Raghav, please don't ask me. Anyone else in the audience has any questions? I think so. There are no questions. Then we can call it off. And there's no oral drugs as such, but I don't know. We used to just write oral riboflavin and trial of that, whether it works or not. But that is just in case if somebody asks you for completion in the viva, or if you want to add little length to your theory.
So interestingly, again, one paper came out of Narayan Netralaya in 20, if I'm not wrong, in 2022, which studied the effects of vitamin D on keratoconus, and it has a positive correlation where use of vitamin D uh, can prevent progression. But still, how effective it is, we still are not sure. But yeah, there are similar papers for vitamin D and omega-3 fatty acids as well in addition to the riboflavin.
I think omega-3 fatty acid and vitamin D are the safest choice in ophthalmology. From
True.
refractive error to everything you can. If you don't know, you just say omega-3 fatty acid.
Yeah. It becomes a right answer. Dry eye, yes. Keratoconus, yes. Allergy, yes.
Anything. So thank you, Dr. Raghav, and thank you, Dr. Aboli. It was a wonderful presentation, and really I appreciate that you've taken your time and agreed to present at such short notice. And hopefully we'll catch up again with Dr. Raghav with some other topic. And thank you, everyone.
Thank you. Well
Thank you, sir.
presented, Aboli. Congrats. If you are doing it in second year, I think you are almost there.
Thank you, sir. Thank you so
no need for
much.
cornea fellowship for Aboli.
Yeah, absolutely. Take care. Thank you. Bye bye.